Good evening, friends. We are here for our Cochin API Cochin branch meeting, monthly meeting. I welcome you all. Meeting is called to order. Today we are directly going. We got two sessions today. There are four clinical case discussions followed by our general body meeting. First, without wasting our time, we are going for the clinical case presentation. I invite Dr. Jilse George to open the session. Before that, Dr. Jilse George doesn't require any introduction to this gathering, but still customary. He is ex-principal of Government College, Ernakulam, and is the HOD of Medicine and Government Medical College, Ernakulam. And he was our ex-chairman, API Kochi branch. With these few words, I invite Dr. Jilse George to the podium. Please welcome, sir.
Good evening to all my senior colleagues and my dear friends. Today, we are presenting three presentations today we are having. We will start with the first presentation. Presenter is Dr. Nithya Jose, third year MD General Medicine student. The topic they named it as, Dr. Sumesh and Dr. Abraham named the topic as Medicine, a Science or Art. Here, we are presenting a series of cases with a clinical, each case will take some 2 to 3 minutes. And at the end of each presentation, we will ask you the differential diagnosis, 3 minutes. And we will show the MRI report, and then we will tell the final diagnosis. Okay, Dr. Nithya, please. We want your active participation in the clinical discussions. Then only it will be a lively program. So, everybody has to actively participate in the clinical discussions.
Good evening, all. At the outset, let me thank Dr. Jilse, sir, HOD, General Medicine Department of Government Medical College, Ernakulam, for giving me this opportunity. So let me begin with the case discussion. So I present to you a series of cases which came to our OPD and in our department records when the face switches to the emotions.
It is a series of cases for last 4 or 5 years.
First case, it is a 58-year-old female, a known case of seizure disorder on levetiracetam and clobazam, came with the following complaints: numbness and paresthesia of face since 2 years, twitching movements of face since 2 years, inability to close the eyes since 4 days, both eyes since 4 days, difficulty to speak since 4 days, and giddiness since 4 days. The patient gives history of numbness, paresthesia, and tingling sensation of face since 2 years, and these complaints were symptomatically managed. Later, she noticed switching movements of the face with deviation of angle of mouth. These movements were repetitive and stereotyped, preceded by numbness, paresthesia, and tingling sensation of the face. She was investigated for the above complaints, and her blood investigations were within normal limits. EEG was done and within normal limits. CT brain was done, and it was also within normal limits. Hence, the dose of her anti-epileptic drugs were hiked, but the complaints recurred. She was symptomatically better afterwards, after adding carbamazepine.
Yes, what is your provisional diagnosis? Is the treatment is going in the right line, or anybody has got a difference of opinion in this case? First part, numbness, paresthesia, almost stereotyped, coming for the last 2 years. Later it becomes it turned to a twitching movements of the face involving the angle of the mouth as well as the entire face. The movements are almost stereotyped and something like a tremor. So, what are your diagnosis, or what are the challenges in this case? Yes, this patient was given treatment, and what is the reason for diagnosing it as a case of seizure disorder and starting the treatment, and patient becomes better with that? Yeah, epilepsy is a simple partial seizure. That means the patient is getting paresthesia, numbness repetitively for the last 2 years. So, it's, as sir very correctly told, as we are physicians seeing for the first time, we will diagnose it as a simple partial sensory seizure. But we have to explain one more thing. There are after some 2 years, patient started twitching movements on the face on one side. How will you explain that? Simple partial sensory seizure. If I am the physician, my diagnosis will be that. Agreed. Then why there is twitching movements? How will you collaborate it?
So there is a motor involvement.
Yeah, what is that due to? Is it a facial tick or a facial twitching
Hemifacial spasm.
or hemifacial spasm? Hemifacial spasm comes as not as a tremor. It will be like this. വലിച്ചു കൂട്ടിയിട്ട് ഇങ്ങനെ നിന്നും പിന്നെ വിടും, പിന്നെ വലിച്ചു കൂട്ടും വിടും. Unlikely. And it is not a stereotyped phenomenon.
But the patient is going to status.
Status, it is not persisting for more than 10-15 minutes. Status means it has to present throughout and there should not be any period of consciousness in between. Anybody come up with yes? Sir, it can be simple partial seizure with a secondary generalization to simple partial motor seizure. അതായത് SPMS എന്ന് പറയുന്നത്. So that is the diagnosis, and that is why the neurologist hiked the doses of anti-epileptic drug, levetiracetam and also carbamazepine. Okay, then. So that is the provisional diagnosis. We excluded hemispatial spasm, tics, other twitching movements, etc. We can safely rule out in this state. Okay.
After 3 months, she came to the OPD with bilateral facial palsy along with aggravation of her sensory symptoms.
This is the stage where we saw the patient in our OPD. She came with an immovable face, unable to close the eyes, no expressions, nothing. Actually, this started in the midnight, soon after her family life. Suddenly she developed this problem and she was brought into the casualty. That was the history, to be very frank.
So we
her MRI was normal at that time and the EEG also was normal. We did an MRI.
And it revealed small vascular loops which were seen intending the bilateral trigeminal nerves at the level of CP angle cistern, and small vascular loop intending the bilateral facial and vestibulocochlear nerve sheath complex at the level of CP angle cistern.
So at the level of CP angle, there is an abnormal loop of artery, that is the anterior inferior cerebellar artery, which is at the level of the CP angle, touching both the 5th nerve as well as the 8th nerve bundle. So that is why he is getting the twitching movements. Whenever that touches that area, he gets the movement. Yeah, pain was not very classically told by the patient.
Tingling and numbness.
Motor component involved with that. It has got 2 parts.
Trigeminal neuralgia.
Trigeminal.
Trigeminal
Narrow is affected.
Yeah, so trigeminal neuralgia we expect in this case.
Yeah, but patient is not complaining that. We repeatedly ask the patient. So this is one case. So this is a loop, abnormal loop, which is responsible for the symptoms. അവസാനം വേറെ കാര്യം ഇവിടെ പറയാം. Okay. Second case.
The second case, this is a 65-year-old female who was brought to the ENT OPD with complaints of on and off left-sided earache since 3 years. The patient also gives history of fullness of the left ear with tinnitus. She was evaluated and on examination her tympanic membrane and external auditory canal were normal. Her blood investigations were within normal limits and she was symptomatically managed. After 1 month, she was brought to the casualty with severe left-sided earache, tinnitus, vomiting and vertigo. MRI brain and ear was done and found to be normal. Next day, the patient developed left element facial palsy. Examination findings were also suggestive of a left-sided element facial palsy.
This patient came with a severe pain in the left ear. He came to the OPD. First consulted the ENT surgeon. ENT surgeon, they finally diagnosed it as a case of tympanic neuralgia. And they started medicines. But after some time he came to our again to the ENT OPD with a left facial nerve palsy, so that patient was referred to our OPD.
After a few hours, there was complete recovery of her symptoms and hence she was discharged. But after 3 days, she came to the OPD with similar complaints and detailed history revealed that the symptoms were precipitated by emotions and stress.
What may be the provisional diagnosis in this case? So came with the earache, severe pain in the tympanic membrane. Then this is preceded by a left-sided facial palsy, recovered abruptly. Recovery within another 1 hour, patient recovered. No convulsions. Conversion syndrome. Yes, conversion syndrome is a possibility, but it will not recover so fastly. Varicella virus persistent facial palsy. It will be persistent for minimum 1 week. It will take for recovery.
Gradenigo. Gradenigo. That one of course disappear. Gradenigo syndrome.
Gradenigo syndrome also disappear so abruptly. It will take 2-3 weeks. Even 1 month is the time for recovery, and the pain will not be there. What all severe pain in the ear, tinnitus.
So this was an MRI report wherein we saw a left anterior inferior cerebellar vascular loop which crosses the left 7th and 8th cranial nerves at the left internal acoustic meatus.
So almost same picture, anterior inferior cerebellar artery crossing the nerve nucleus, and there is a small aneurysm like thing which is just lying over the vestibular nucleus. That is why he was getting the tinnitus, numbness and other pain, etc. Along with the facial nerve is compressed, she is getting left facial nerve palsy. So, yeah, it is the report. Now, this is the report.
This is the red arrow points towards the anterior inferior cerebellar artery compressing the facial nerve. Next case, it is a 31-year-old female who came to us with complaints of intermittent episodes of numbness, paresthesia, tingling sensation of face since 2 years. The complaints were usually preceded by strenuous activity. She also had 2 episodes of deviation of angle of mouth to the right side, which recovered completely after taking rest. Her blood investigations were including electrolytes, tests for collagen vascular diseases were normal. MRI brain taken at that time was normal. A diagnosis of simple partial seizures were made and she was started on anti-epileptic.
Yes, this is having this almost the same presentation, but this patient and the clinical symptoms are typical of a simple partial seizure. Numbness again confined to one side.
4 months later, she came with left-sided LM and facial palsy. A provisional diagnosis of Bell's palsy was made and she was started on steroids. The next day, the patient had full recovery. Hence, an MRI brain was done again and this was a finding. Similarly, a small vascular loop was seen intending the left facial and vestibulocochlear nerve sheath complex at the level of CP angle cistern.
Third case, almost the same presentation, a vascular loop is there. But the previous MRI, their dead was normal. I will tell you what is the reason at the end.
Next case, we had a 61-year-old female who complained of intermittent tinnitus and vertigo. She was evaluated. Her blood investigations and imaging studies were within normal limits, and she was started on vestibular sedatives, after which she became symptomatically better. After 3 months, she experienced twitching of upper lip and lower lip along with tinnitus and vertigo. The examination done during her hospital visits, usually after the symptom relief, were normal. Her EEG was taken, which was also normal. The MRI brain taken later revealed the diagnosis, and a small vascular loop intending the left facial and vestibulocochlear nerve sheath complex was seen. Next is a 15-year-old male who complained of tinnitus in the right ear during activities like playing shuttle and running. The symptoms gradually progressed and he had giddiness on exertion, which forced him to take rest for a few minutes. Later on, he noticed recurrent intermittent twitching movements of the face and mild facial weakness. Blood investigations were normal and MRI brain was taken, and we saw anterior inferior cerebellar artery looping around the facial-vestibulocochlear complex on the right side. 2 other patients, a 54-year-old male and 68-year-old female, also had similar complaints, and their MRI reports were as follows. In both cases, we saw anterior inferior cerebellar artery which forms a loop around the 7th and 8th nerve at the CP angle cistern.
why we presented these 8 cases is, when it's a usual practice in our clinical, because of busy schedule, we will just write MRI brain. And when we discuss the case with the radiologist, and we have told them the exact clinical history, this is the scenario. They are getting recurrent episodes on and off, recovering completely in between. That history we are given. So they specifically looked for the conditions that can produce this type of neurological presentation. That is, we will get a transient weakness followed by recovery. Then again he gets the same problem. So why we presented is, whenever we write for investigation, this is for our PG students, you have to write the clinical notes before sending any patient for MRI study or a CT scan or a peripheral smear. This was a lesson for us also. So that is why we presented this series of cases before you. One patient with a history of severe pain radiating this area, mandibular neuralgia was first diagnosed. Later, a dental surgeon asked her to remove the tooth because of the severe tooth pain like that. That mandibular neuralgia presented case. So that is why we presented these cases. So all these cases, MRI done previously, they just looked into the MRI report and the CP angle, no tumor, something like that, they will write and they will simply send. If you write clinical history specifically, they will also force to look specifically for any particular reason, so the diagnosis will come. So we presented this case only to stimulate your further this thing, to write clinical symptoms and signs and clinical features when we are ordering for relevant investigations.
Thank you.
Okay. Next case will be presented by Elsu Bejoy. This is an interesting case in which we also went wrong in between, but finally with the thanks to God, we made a final diagnosis. So listen to the clinical history, and Dr. Joy is here.
Good evening, everyone. I thank Dr. Jilse, our HOD, and AP Kochi for giving me such an opportunity. And my case is here, nothing is hidden under the sun. My patient is Sushila. She is a 45-year-old female from Tripunthara. She came with the complaints of extensive vesicles, bullae on face, hands and foot for 2 weeks. Yellowish discoloration of urine and conjunctiva for 1 week. Generalized itching for 1 week. Persistent vomiting for 3 days. The history of her presenting complaints were, the patient, she had a very long history. Patient started the symptoms at the age of 28 as pain and swelling of small joints of hands, bilateral elbow, ankle and hip joint, for which she was investigated. Her investigation showed the HP 10.1, CRP positive, total count 10,000, and polymorphs 78, lymphocyte 20, ESR 80, RA factor negative and ASO positive. She was diagnosed as rheumatic arthritis from local hospital and was taken treatment for that, but her symptoms persisted. So she was taken to a Ayurvedic hospital and was diagnosed there as Amavadam, was treated with Dara Kiri for 1 month. Her symptoms reduced following this. She was symptom free for almost 3 years, and at that time patient went to Dubai as a housemaid, and by 3 years she developed pain on bilateral ankle, knee and muscles, or also muscles of calf and upper arm. All movements were painfully limited. She discontinued her job and returned to Kerala. Her relatives noticed tanning on her face and increased body hair growth, attributed it to climate change in Dubai. She was taken to a physician for the above symptoms. And the investigation at that time showed HP 9, ESR 110, platelets 2.6 lakh, and serology negative. Serum bilirubin 2.6, direct 1.9, SGOT SGPT 164 306, RA factor and ASO negative. ALP was 298, serum protein 7.6, albumin 4.1, globulin 3.5. The symptoms were not resolving with her USG showed mild hepatomegaly and mild coarse echotexture. The symptoms were not...
This patient is having some odd findings. All these records are there with the patient because patient is an ESI beneficiary. So book on the kaile. A book in that all details and all investigations are there. We saw that there is history of pain in the legs and other thing. Then but that time the ASO positive, CRP was positive, ESR was high, likely to be rheumatic arthritis, but no prophylaxis were advised to that patient. Second thing, by seeing this investigation, what would have been the provisional diagnosis for this patient?
Hepatitis secondary to naturopathy because the liver enzymes are high and the bilirubin is also an issue.
100%. This patient is having an indigenous medicine induced problems like this. ESR is 9, HB is 9. Only odd finding is ESR is 110, which is unlikely in a patient who is getting a toxic hepatitis. One thing. Then SGOT, SGPT elevation, all other things we can very well explain. And the course echo texture of the liver in USG we can explain, but the only thing we cannot explain is the raised ESR, which is that is also 110 millimeters per hour. That is one point which is we cannot explain by this. Okay.
Her symptoms were not resolving with treatment. Patient developed few skin lesions on upper arm later. She was taken for Ottamuli. There she developed persistent vomiting, nausea, tremors of hands, yellowish discoloration of eyes and urine. She was referred from there to a local hospital.
As usual, being a Tripunithara person, definitely they will go to Ayurvedic treatment. So they took Ottamuli treatment and the symptoms worsened actually.
Due to the persistent vomiting, itching and jaundice, she was referred to a gastroenterologist. She was diagnosed with hemochromatosis from there after the liver biopsy. The details were not available.
But that details the patient is not keeping, so we are not able to present the details now.
Patient underwent repeated phlebotomy and symptoms was improving and was symptom free for almost 8 years. She joined a catering center. There she developed alcohol consumption and she started noticing mild itching there, and she almost worked for 3 years there.
Because the night time to avoid sleep and for smooth working, she was advised to take little alcohol. So she started the practice of consuming alcohol every day, because the marriage in the houses, what we people, the owner will supply the liquor to the catering people. During that time, catering services like this was not fully developed.
Due to the financial reason, patient went to roadworks for 4 weeks before. But she developed itching all over the body, more in the upper arm and feet. She consulted a dermatologist and was diagnosed as photosensitivity, exposure dermatitis, and was given treatment for that. Her symptoms started worsening. Skin lesion increased in size in the last 2 weeks before she was present to us, and there was formation of blebs and vesicles. She was taken to a Vaidyan and was diagnosed as Raktadusham and was given Kashayam and Kurumbu. The lesions flared up, some of them ulcerated, few crusted, more on the face, upper limbs, lower limbs, face and other sun-exposed areas. She consulted a physician in Tripunithara and was referred to our hospital.
With the permission, this case was referred by our own physician, Dr. Ajay Kumar sir, to us. With a provisional diagnosis, I will tell you that with his permission. Can I? Ajay Kumar sir referred this case to us. At the time when patient was brought here, there was smelling like anything. All lesions were generalized lesion. During that time, we were not thinking of this diagnosis. We thought that it is purely because of a drug induced. It was a Stevens-Johnson syndrome, because patient has got hypotension also, all features. So we also, Ajay Kumar sir referred to us with the history of Stevens-Johnson syndrome, most probably drug induced or indigenous medicines. That was his diagnosis. We also accepted that diagnosis and we treated the patient in the same line of treatment. Okay, then.
On examination, ictus was present, clubbing present, extensive ulcerated blebs, vesicles, crusted lesions. There was hyperpigmentation, all creases were hyperpigmented, and there was bilateral pitting pedal edema. Her investigations counts were raised 19,000.
This photograph is in the healing state, because at the time we did not take any photograph because we never thought that it is another diagnosis other than Stephen Johnson's.
ESR 118, HB 7.2, platelet 56,000. URE showed albumin, albumin plus, urea creatine 104 and 2.8, sodium potassium 135, 3.5, serum bilirubin and direct 8.8 and 6.1, SGOT, SGPT 586 and 668, serum protein was 5.3, albumin globulin 2.1 and 3.2.
So AG ratio is reversed. AG ratio is reversed, thrombocytopenia is there, serum bilirubin is high 8.8 and it is mainly a direct bilirubin. Creatinine, there is a kidney involvement also with the raised serum creatinine and blood urea. Then albumin is also present in the urine, so there is involvement of the basement membrane also is there. Platelet count is 56,000 again. Then HB hemoglobin, previously it was normal, now reduced to 7.2. ESR remains the same, 118, 120, in that range it is remaining. Then total count is also high, 19,252 with the polymorphs 82. Why? For the juniors. So it is a clear-cut case of an infection is there in the body. One. Second, HB 7.2, platelet count low, then creatinine, liver involvement as well as kidney involvement. Everything points to the fact that there is some sort of septicemia or sepsis developed in the body with the evidence of multi-organ dysfunction syndrome, MODS.
CRP was 68, ANA negative, APLA negative and RI negative.
CRP 68, clear cut. There is an inflammatory or infective lesion or process is going on in the body of the patient.
And the iron study showed serum iron 39, total iron binding capacity 276, serum ferritin 456%, transferrin saturation 50.7, and D-dimer was positive.
Now also patient is having evidence of hemochromatosis and D-dimer is positive. That means that our clinical impression is it is because of DIC.
And in X-ray there was blending of CP ankles. The USG showed
most likely bilateral pleural effusion.
USG showed hepatomegaly, liver span 16.8, coarse echo texture, and there was mild ascites.
So this was the picture when this patient was brought into the casualty and admitted in our hospital. So what are the possibilities you like to encounter? Blood sugar was normal actually. Biliary tuberculosis, any other evidence of tuberculosis? X-ray chest is almost normal except that bilateral pleural effusion. Bilateral small pleural effusion in this stage. Yeah, biliary tuberculosis, full further evidence of tuberculosis should be there. Mando should be positive or some other supporting evidence. There is a chance that it can be biliary tuberculosis, but the skin lesions we cannot explain by biliary diagnosis. That is Stephen Johnson. Porphyria, yes, there is a possibility. Yes, then tell us some possibilities. നമ്മൾ ഡെയിലി കാണുന്നതാണ്. അതെ, ഈ ഇൻവെസ്റ്റിഗേഷൻ ഇത് ശരിക്കും പറഞ്ഞാൽ CPS ആയിട്ട് ആരെക്കൊണ്ടും ഡിസ്കസ് ചെയ്യിക്കണ്ട. നല്ല കേസല്ലേ? ഓക്കെ, ദെൻ പ്രൊസീഡ്. leptospirosis, then kidney involvement, liver involvement, thrombocytopenia, all pleural effusion, ascites, all things are in favor of a leptospirosis, except the point is why there is a high total count and high ESR count are the two odd points. But the skin lesions are, we cannot explain by a leptospirosis diagnosis. That a long duration of illness also is a point against leptospirosis. Come up, ഇനിയുണ്ട് ഡിഫറൻഷ്യൽ ഡയഗ്നോസിസ്. അന്നെങ്കിൽ ഇത് ലൈവ്ലി ആവുള്ളൂ, അല്ലെങ്കിൽ ചുമ്മാ നമ്മൾ എന്തോ വെരി ഗുഡ്. It's a stage where we have to think of a pemphigus, very important.
With secondary.
Yeah, with the second. That is one of the most important diagnoses to be entertained in this patient. But one thing is, such an extensive pemphigus will die even before that, because it's a medical emergency. Sudden death can occur very so very soon, when this much skin eruptions and lesions are occurred. You know, there is a sign called sign where the epidermis slips over the dermis. What is that sign? Close kiss. Okay. Then we will proceed to the further.
We made a clinical diagnosis of Stevens-Johnson's disease with sepsis and also with multi-organ involvement. So the patient was treated with antibiotics and also supportive treatments was given. But after 5 days of treatment,
there was a dispute in our department. One is Stevens-Johnson syndrome, and my diagnosis was 10. I'm telling frankly, toxic epidermal necrolysis. But my other colleagues were not agree. They are Stevens-Johnson, stick on to that. Then we thought we will treat it symptomatically. So we started treating it symptomatically without a very correct diagnosis. There are other possibilities. As sir told, pemphigus is a possibility. Then epidermis bullosa, bullous lesions can develop in a patient without much systemic involvement. And we were in a situation where we cannot make a diagnosis of this particular case. One day, while walking to the ward for rounds, Jilse, he was working during that time with me. He told me that സാറിന് ഇന്നൊരു സമ്മാനം പിള്ളേർ വെച്ചിട്ടുണ്ട്, അങ്ങോട്ട് ചെല്ലെന്ന് പറഞ്ഞു എന്നോട്. ഞാൻ ചോദിച്ചു എന്താണ് ഈ സമ്മാനം വെച്ചിരിക്കുന്നത് ചോദിച്ചു. ഉണ്ട്. അപ്പം ഞാൻ വിചാരിച്ചു എന്തോ ഗുലുമാലോടെ ഉണ്ടാക്കിയിട്ടുണ്ട് സോൾവ് ചെയ്യാൻ വേണ്ടി എന്ന് വിചാരിച്ച് നമ്മൾ ചെന്ന് കഴിഞ്ഞപ്പോൾ they made a very good observation regarding the patient. That is the thing. 5 days of treatment in our hospital. One day, one of our resident noticed a very interesting finding. See this: a violaceous tinge of urine in the urine bag. പേഷ്യൻ്റ് കത്തീറ്ററൈസ് ചെയ്തിരുന്നതാണ്. യൂറിൻ ബാഗിൻ്റെ അകത്ത് നമ്മൾ സൂപ്പർ വൈറ്റ് ഒരു തുള്ളി ഒരു വെള്ളത്തിലേക്ക് ഒഴിച്ചാൽ എങ്ങനെ ഇരിക്കും, ഏകദേശം അതുപോലെ ഇരുന്നു. ആ ഫോട്ടോഗ്രാഫ് ഉണ്ട്. ഓക്കെ. So that was the interesting finding we got on that particular day. So what is the most probable diagnosis? By seeing this finding in our clinical discussion or rounds, we saw a finding like this. So was pointed out by 2 PGs. Another PG was Dr. Minhaj. He completed and left. This was the സമ്മാനം ജോയ് സാറിൻ്റെ ഭാഷയിൽ പറഞ്ഞാൽ വെച്ചിരുന്നത്. ഈ ടിഞ്ച് this lastly helped us to make a diagnosis. What are the possibilities? അതായത് ജസ്റ്റ് നമ്മൾ സൂപ്പർ വൈറ്റ് ഒരു ഗ്ലാസ് വെള്ളം എടുത്തിട്ട് കുഞ്ഞ് ഡ്രോപ്പ് സൂപ്പർ വൈറ്റ് അതിൻ്റെ അകത്തേക്ക് ഒഴിച്ചിട്ട് മിക്സ് ചെയ്താൽ എങ്ങനെ ഇരിക്കുന്നത്, സോ അതിൻ്റെ മുകളിലേക്ക് നോക്കി എങ്ങനെ ഇരിക്കും, എക്സാക്ട്ലി ദാറ്റ്. അപ്പോൾ എൻ്റെ സിസ്റ്റർ പറയും ഞാനിത് കണ്ടു തുടങ്ങിയിട്ട് ഒരാഴ്ചയായി സാർ. ഞങ്ങളിത് പറഞ്ഞ് വലിയ സീരിയസ് ആയിട്ട് ഡിസ്കസ് ചെയ്തപ്പോൾ ഇത് എന്തൊക്കെയായിരിക്കും 1 2 3 4 എന്ന് പറഞ്ഞപ്പോൾ സിസ്റ്ററിൻ്റെ കമൻറ്റ് ചെയ്തായിരുന്നു. ഓക്കെ നെക്സ്റ്റ് വൺ. സോ വാട്ട് ഈസ് യുവർ ഡയഗ്നോസിസ്? അല്ല, വാട്ട് ഈസ് ദ പോസിബിലിറ്റീസ് പറഞ്ഞില്ല. One is porphyria, porphyria, that is one diagnosis. Second is അത് കണ്ടിന്യൂസ് ഒരു ഡാർക്ക് കളർ, ലെപ്റ്റോക്കൊക്കെ വരുന്ന ഡാർക്ക് കളർ. സെക്കൻഡ് ഈസ് ഓങ്കർണോസിസ്. പിന്നെ രണ്ടാമത്തത് പിന്നെ ഹാർട്ട് നർവ് ഡിസീസ്. ഇതെല്ലാം പിള്ളേരിൽ കാണുന്ന അസുഖങ്ങളാണ്. അഡൾട്ടിലേക്ക് ഇത്രയും വയസ്സ് വരെ ജീവിക്കാൻ സാധ്യത കുറവാണ്. ഓക്കെ, സോ porphyria we suspected actually. Then what to do? Next one.
We sent the samples for serum total porphyrins and erythrocyte total porphyrins, urinary, ALA and APBG, fecal total porphyrins and urine uroporphyrins, stool porphyrins also sent, and all the reports came positive for porphyria cutanea chara.
ഈ ടെസ്റ്റുകളിനകത്ത് നമ്മളിവിടെ പോർഫൈറിൻ മാത്രമേ ചെയ്തുള്ളൂ. പോർഫൈറിൻ ചെയ്തു, പോർഫൈറിൻ ടെസ്റ്റ് കെയിം ടു ബി പോസിറ്റീവ്. സോ വി മെയ്ഡ് എ ഡയഗ്നോസിസ് ഓഫ് porphyria. Because of the cutaneous lesions, we made a diagnosis of porphyria cutanea tarda. Okay.
And the patient was treated with phlebotomy and HCQ was given, and she was advised to avoid alcohol, and also skin protections from sunlight was advised. And the symptoms were symptomatically improved, and she was discharged.
So this is the situation, but still Yeah, that is a separate, most likely separate porphyria. There is an association of hemochromatosis in porphyrias. So that is the case. And this case, this patient was later taken to, we told them the patient requires further workup because there are different types of porphyria. So and the treatment also to be monitored by a higher center. So they told the one CSI father was there. This patient was with that CSI father in Dubai. So he took her to Vellore Hospital. There one physician, Kerala person, he saw the case and he advised, he referred to gastroenterologist. Gastroenterologist did a liver biopsy and the liver biopsy turned out to be a hepatocellular carcinoma. That was the sad story of this patient. Yeah. Mostly either due to secondary to cirrhosis. Yeah. Yeah, that is most likely. Cirrhosis liver, course tester, everything is there. So I think it hemochromatosis induced cirrhosis liver, which was gone to a hepatocellular carcinoma. That was the final story of the patient. Vellore people, they published this case. They mentioned our names also in that. They published it as a case where patient turned out to porphyria patient, cutaneous tarda turned out to be hepatocellular carcinoma secondary to hemochromatosis association. So this is the case. Porphyria brownish violaceous color എന്നാണ് പറഞ്ഞേക്കുന്നത്. കോഫി അല്ല, ബ്രൗണിഷ്, ഒരു വൈലേഷ്യസ് കളർ. ഇതെന്താ എന്തോ? എക്സ്പോഷർ ടു സൺലൈറ്റ്. Sunlight is the triggering factor. Another triggering factor is alcohol. No, not. Once patient came to us, patient was in a very bad shape. We also thought it is a Stevens-Johnson syndrome. We will lose the patient. And Ajith sir was daily telephoning. What happened? But we could not give a diagnosis at that time. Finally, we got the diagnosis. So this is about one case of porphyria cutaneous tarda, and finally it turned out to be hepatocellular carcinoma.
Thank you.
The third case, this case പ്രസൻറ്റ് ചെയ്യാൻ ഇരുന്ന PGയുടെ ഫാദർ ഇന്ന് ഉച്ച കഴിഞ്ഞ് മരിച്ചു. അപ്പോൾ ഷീ കുഡ് നോട്ട് ടേൺഡ് അപ്പ്. അപ്പോൾ എമർജൻസി ആയിട്ട് വീട്ടിൽ പോയി. അതുകൊണ്ട് ആ കുട്ടിക്ക് പ്രസൻറ്റ് ചെയ്യാൻ പറ്റിയില്ല. ഈ പ്രസൻറ്റ് ചെയ്യാൻ ഉണ്ടാക്കി വെച്ചിരുന്ന മെറ്റീരിയൽസും കാര്യങ്ങളും എല്ലാം ആ കുട്ടിയുടെ മുറിയിൽ പെട്ടെന്ന് പോയതുകൊണ്ട് ആ കുട്ടിയുടെ മുറിയിലായി. എങ്കിലും നമ്മൾ ആ കേസിൻ്റെ ഹിസ്റ്ററി വീണ്ടും ഈ കുട്ടി, ഇത് ഫസ്റ്റ് ഇയർ സ്റ്റുഡൻ്റാണ്, ഫസ്റ്റ് ഇയർ സ്റ്റുഡൻറ്റ് അതിൻ്റെ ഹിസ്റ്ററിയൊക്കെ ഉണ്ടാക്കി ഇത് പ്രസൻറ്റ് ചെയ്യുകയാണ്. അതുകൊണ്ട് പ്രസൻറ്റേഷനിൽ കുറച്ച് കുറവുകളൊക്കെ വരും. അത് പ്ലീസ് എക്സ്ക്യൂസ് ഹർ ആൻഡ് യു ക്യാൻ ആസ്ക് എനി ക്വസ്റ്റ്യൻസ്. ദാറ്റ് ഈസ് മോസ്റ്റ് വെൽക്കം. Ask more questions to her because she is in the beginning stage, first year, but 1 month ആകുന്നേ ഉള്ളൂ ജോയിൻ ചെയ്തിട്ട്. MD ജനറൽ മെഡിസിൻ ഫസ്റ്റ് ഇയർ സ്റ്റുഡൻറ്റ്. ആൻഡ് ഷീ ഓപ്റ്റഡ് എറണാകുളം. അതാണ് എൻ്റെ ഏറ്റവും ഫണ്ണിയസ്റ്റ് തിങ്. ഷീ ക്യാൻ ഗോ ഫോർ ഹയർ ഓപ്ഷൻ ബട്ട് ഷീ കണ്ടിന്യൂഡ് ഇൻ എറണാകുളം മെഡിക്കൽ കോളേജ്. ഓക്കെ.
Good evening everyone. Thanks for our HOD sir and IMA Kochi for giving me this opportunity. Going to case discussion.
This also history is very important in diagnosis. So I listen to the history.
16-year-old female patient born and brought up in Kochi. At the age of 16 years, she was having complaints of numbness and paresthesia along both hands and fingers on both sides, more in rainy seasons. Later, she experienced similar complaints in both feet also. Aggravated by walking in rains while going to school, parents ignored her complaints as it was due to her resistance to go to school. She studied up to 10th standard and later joined for a typewriting course. She found it difficult to do typing for a long time as she developed tremors of the fingers and hand, and she feels extreme fatigability and pain in fingers, and there was decrease in speed of typing. She then consulted a local doctor and advised some blood tests and X-ray hands was done, and he was advised to take tab neurobion. There was no relief and she was taken to a physician. Her all records showing the following reports. Her HB was 17.6, total count was 8064. Then differential count was 70% neutrophils and 23% lymphocytes. ESR was only 2. PCV was 54. And they done serum erythropoietin level, which was normal. Her FBS, RFT lipids levels were also normal. And diagnosed as having excess blood in body, which is obstructing the free flow of blood, and polycythemia, and she was advised phlebotomy.
Let's see. Will this diagnosis will explain her problems? That is the situation we are facing. This patient, 16-year-old girl, little backward. That is why she is 18 years and still going to the school in learning. And she is complaining of numbness and paresthesia. And her results are this. So this results is okay. Like polycythemia, there is I don't think any difference of opinion. It's a polycythemia, and it is a polycythemia rubra vera. That is a primary polycythemia, because already patient HP is 17.6. Then ESR is only 2 because the blood is so concentrated. Then PCV is 54, enough to make a diagnosis. More than 50 is the diagnostic baseline. Once it is above 48, we can diagnose, but above 50 means patient requires phlebotomy. Then erythropoietin level is normal. At this stage, we have not done the JAK2 mutation because this time we have not investigated. It is investigated outside. So they started on with the polycythemia and phlebotomy. We fully agree with this, and the physician started this treatment.
She had some relief with the procedure and she continued it for some time at IMA blood bank. Medical officer of the blood bank advised hematology consultation, and tab hydroxyurea was also added. But her pain and numbness continued while doing the typing course. She consulted an orthopedic surgeon and was advised to do.
But phlebotomy was done. She got some relief, but her symptoms of numbness and paresthesia occurring more with doing typewriting course, and there is little pain, and and some movements, tremors, and there is some tremors also in the hand. But what is your probable diagnosis? The polycythemia patient is proven, no doubt. Patient presenting to us with the complaints of numbness, paresthesia, fatigability, inability to type fastly because the speed is slowly coming down. So what is the most probable diagnosis? B12 deficiency affecting upper limb without affecting the other areas, especially in the lower part, is very unlikely presentation. Then the subacute combined degeneration also will not produce any upper limb problems. Sickle cell anemia is a possibility, because why there is increased problems, paresthesia, fatigability, pain on exertion. She is doing typing. So there is no anemia in this patient, but there is polycythemia. There is a strong point against sickle cell anemia. Otherwise, when sickling crisis occurs, we can get this same problem. But I agree. Yes, you come up. Yes. Cervical cord problems definitely is a differential diagnosis. Yeah, any craniovertebral anomaly like platybasia, multi-area malformations, clippal field anomaly, atlantoaxial dislocation, all this can come as a differential diagnosis. But here, in this stage, we don't know whether there is any limitation of movement of the neck, or there is pain on bending the neck, or a short neck, or low set hairline. That is, the Fields triad should be there to make a diagnosis of craniovertebral anomaly. But we don't know whether it is there or not. Yeah, she has got symptoms on the feet, so it is a point against a craniovertebral anomaly. More than that craniovertebral anomaly, there is another fitting diagnosis. 2, 3. 2, 3. Another fitting good diagnosis. Syringomyelia. Yes. But it should be persistent. വന്നിട്ട് പോകില്ല. ഇത് ടൈപ്പ് ചെയ്യുമ്പോൾ മാത്രമോ ടൈപ്പ് ചെയ്യുമ്പോൾ എക്സേർട്ട് ചെയ്യുമ്പോൾ മാത്രമോ മനസ്സിലായി? അതുപോലെ സിറിങ്കോമൈലിയാണെങ്കിൽ എപ്പോഴും കാണും അത്. ആൻഡ് ദെയർ വിൽ ബി വേസ്റ്റിംഗ് ഓൾസോ. വേസ്റ്റിംഗ് ഇസ് എ മസ്റ്റ്. ആൻഡ് എയർലി ബ്ലാഡർ ഇൻവോൾവ്മെൻറ്റ് ഈസ് അനദർ മസ്റ്റ്. യെസ്. സ്റ്റിൽ ഇറ്റ് ഈസ് എ ഡിഫറൻഷ്യൽ ഡയഗ്നോസിസ്. യെസ്. Electrolytes normal. Yes. Compressive lesion like vascular lesion. We don't know at this stage. Vascular lesion we can keep it as a possibility. For example, cervical rib. Very good. Cervical rib is the first thing to suspect in this patient. Yes, cervical rib and scalenus anticus syndrome. They will go both hand in hand. This is the first diagnosis we will suspect in this case. Bilateral. Bilateral. It can occur bilaterally also. Bilateral cervical rib. Common is bilateral. Yeah, symptoms usually starts in one day. There is one test to diagnose cervical rib. This for AdSense test. Okay. Proceed.
She consulted.
Another thing, the orthosurgeon did a very interesting workup. Carpal tunnel syndrome. Yeah, NCV is not. Yeah, lower limb will not be involved. Okay, next.
She consulted an orthopedic surgeon and was advised to do nerve conduction study, and the nerve conduction study was normal. RF factor was done which is negative, and the uric acid levels were normal. As she was not getting any relief of small joint pain with NSAIDs, she was put on steroids and physiotherapy, but the medical shop people explained the grave side effects of steroids and they stopped all the drugs. She then consulted in an Ayurvedic hospital after that. They admitted her and diagnosed Pillavadam and treated with Dana, Kiri, Vasi, etc. for 1 month, and she got good relief. Meanwhile, her marriage was fixed and symptoms were not relieved fully. She was taken to a neurologist for her exertional weakness, clumsiness of hand, and extreme fatigability while working as advised by her local doctor.
She is getting the similar complaints again. Her marriage was fixed, so she was advised by a person who is sitting among us to go to a neurologist because there is exertional fatigability. Then it will recover taking rest and little pain and such other things. So she was referred to a neurologist. It's the right decision, I think. And there was a suspicion also. Case sheet.
He diagnosed and treated it as myasthenia gravis and started on pyridostigmine. Then her husband was working in Munnar and she...
Being with this diagnosis, focal myasthenia gravis. Yeah, that is one important word point. One thing. Second. Yeah, but myasthenia can occur anywhere. There is no need that ptosis should be the first symptom. Myasthenia can occur at any... Yeah, but it can occur anywhere and it can come. And I think it is a fitting diagnosis because she is getting this everything on exertion. If you are confining only to the pain, numbness, paresthesia and tremor movements, but the tremor movements we cannot explain. That is also we can explain fatigue. Pain myasthenia is very, very unlikely. Once pain is there, it is not myasthenia. Yeah. Morning, evening variation also is not there. Diurnal variation also is not there. So these are the points against myasthenia as far as when we retrospectively analyzing the patient. Stress, emotions, etc. can. Muscle weakness in this stage also, there is no much muscle weakness. If muscle weakness is there, it should be persistent. Here, fatigability is the main problem, I think. Fatigability, paresthesia, numbness. No, that we are not done the things. These are done from the history of the patient. She is keeping a bundle of investigation reports. And another diagnosis in this stage can be undertaken a seizure in this stage. Simple partial seizure, paresthesia, numbness, bilateral symmetrical. symmetrical, stereotyped. Can we entertain this as a seizure? What are the points against a seizure in this patient? Focal seizure, focal motor seizure, or sensory seizure with a secondary generalization. That is why motor symptoms also started. So anyhow, this is a stage. Okay, proceed.
Her husband was working in Munnar and she got settled there and her symptoms got aggravated. Since she was staying near to Kundala Dam, she used to go to the reservoir area for washing clothes and taking bath along with neighbors. While standing in the reservoir bank washing the clothes with hands, that is upper limbs hanging down, the symptoms of pain, numbness, tingling of fingers got aggravated and there was severe pain in feet also. Due to prolonged washing, her extremities looks pale and skin appears shrinked.
Any clue? Anything you want to add? Reynolds. Okay, pinne. Okay, proceed further, then we will discuss.
Her neighbors and friends took her to the estate doctor and he referred her to Ernakulam with these clinical notes. And
this was a reference given to this patient. ഞാൻ മോളിലപ്പം കയറി കളഞ്ഞ ഡോക്ടറുടെ പേര് പറഞ്ഞാൽ ഇഷ്ടപ്പെടുമെന്ന് അറിയത്തില്ല. നമ്മളൊക്കെ അറിയുന്നയാളാണ്. ഒന്ന് വായിച്ചത്
I'm referring her with pain and numbness on both hands and fingers while washing the clothes in bending forward position with the arms hanging down to rule out thoracic outlet syndrome, cervical rib or scalenus syndrome, subclavian artery obstruction, brachial plexus injury. Please do the needful and give a note regarding this. May bless you.
So this is the reference letter given by that patient. When we discuss this case in our hospital, we ask the PG students, this diagnosis is suitable to this patient. General physician patient, estate doctor, നമ്മൾ ഇത്രയും തന്നെ മോർ ദാൻ ഇനഫ് എന്ന് വിശ്വസിക്കുന്ന ഒരാളാണ് ഞാൻ. ലോങ് ടൈം എസ്റ്റേറ്റിലൊക്കെ വർക്ക് ചെയ്ത് കഴിയുമ്പോൾ നമ്മളൊക്കെ ഇതുപോലെ ആവും. അല്ല, ഇത് കുഴപ്പമില്ല. കാരണം എന്താണെന്ന് വെച്ചാൽ നമ്മൾ ആ പൊസിഷൻ അസ്യൂം ചെയ്ത് നോക്കിയാൽ മതി. ഇങ്ങനെ നിന്നിട്ട് നമ്മൾ തുണി ഇങ്ങനെ വാഷ് ചെയ്യും. ഹാൻഡ്സ് ആർ ഹാങ്ങിങ് ഡൗൺ. സോ ഓൾ ദ സർവൈക്കൽ പ്രോബ്ലംസ് വിൽ ബി പ്രിസിപ്പിറ്റേറ്റഡ് ബൈ ദിസ് ആൻഡ് ഓൾ ദീസ് തിങ്സ് വിൽ റിലീവ്ഡ് ബൈ റേസിംഗ് ദ ഹാൻഡ്. അപ്പോൾ തുണി ഇങ്ങനെ വാഷ് ചെയ്യുമ്പോഴല്ല ഹാങ്ങിങ് ഡൗൺ ചെയ്യുമ്പോൾ സർവൈക്കൽ റിബ് ആയാലും സ്കെലീനസ് ആൻറ്റിക്കസ് സിൻഡ്രോം ആയാലും പിന്നെ thoracic ഔട്ട്ലെറ്റ് ആയാലും ഔട്ട്ലെറ്റ് ഒക്കെ ആയാലും ഇതെല്ലാം എക്സാസർബേറ്റ്. നമ്മളതിനെ ഡയഗ്നോസും നോക്കുമ്പോൾ കിട്ടാതെ നമ്മൾ അസൈൻ ചെയ്ത് നോക്കില്ല എങ്ങനെയാണ് ഉണ്ടാകുന്നത്. അങ്ങനെ നോക്കുമ്പോൾ ഐ ഹാവ് ഫുള്ളി എഗ്രീയിങ് വിത്ത് ഹിസ് ഡിഫറൻഷ്യൽ ഡയഗ്നോസിസ്. ഓക്കെ.
She was fully investigated and the reports are shown below. Her HB was 18.2, ESR was 2.
Still that polycythemia part is persisting.
PCV was 54. URE, left RFT were normal. Chest X-ray was done. Doppler, upper limb and lower limb was done, which was normal.
So the vascular component, coaches are, it is normal now. But now the Doppler report is ready. So vascular part is normal. MRI cervical area is normal. So all this diagnosis, cervical rib outlet, thoracic outlet syndrome, craniovertebral anomalies, scalenus anticus syndrome is the only thing remaining which we cannot diagnose by an MRI or dynamic MRI you have to do. Okay.
Then JAK2 mutation study was done and it was present. Based on this, she was again advised phlebotomy and put on hydroxyurea, silastazole, aspirin and endoxit. She went back to Munnar with full confidence, but after 6 to 8 months, her symptoms again started along with pain at the tip of nose, earlobes and cheeks with paleness on exposure to cold wind and rains in Munnar. Since her symptoms got aggravated during raining and winter seasons, she returned to Kochi and consulted her all general physician, Dr. P.V. Jilse. He brought the patient to our hospital. And this is the patient.
Anything we can can make a diagnosis by seeing the patient. Any? Yeah, there is exophthalmos. Agreed. Pinne. Agreed. Pinne. By seeing the patient. Yes, tell me. Scleroderma. Yes, strong. Why you are thinking scleroderma? Your mouth is small. See. Okay. Then next. ജോയ് സാറിൻ്റെ പേഷ്യൻ്റാണ്. ജോയ് സാറിനോട് ഭയങ്കര സ്നേഹമുള്ള പേഷ്യൻ്റ്. ചെറുപ്പം മുതലേ ജോയ് സാറിൻ്റെ സ്വന്തം ആളാണ്. ഓക്കെ. വീഡിയോ ഇല്ലേ? You see this video. So the lower lid is not at all moving. It is almost fixed. Muscle, very difficult to hold it. See? Very difficult to pull it. See the mouth. The skin in the neck. കയ്യിലെ സ്കിൻ ജനറലൈസ്ഡ്, ഡിഫ്യൂസ്. Since we are having no diagnosis, we are spending some time. That is our usual practice. When there is no diagnosis, after rounds we will sit there with a cup of tea and we will re-examine the patient. So this is the time we are re-examining the patient. See the hand. All areas, knuckle pigmentation, everything is very clearly seen. This is a point one day told by Dr. Puthuran sir. Whenever you are getting knuckle pigmentation, think of 4 conditions. You are remembering, sir? Okay. So this is the okay. Next. Time palikkanam.
Then examination findings include there was thickened skin, small mouth, dental caries, knuckle pigmentation, and all skin creases were hyperpigmented.
Before that, this patient, because of her complaints of മൂന്നാർക്കൂടെ നമ്മൾ കാറ്റടിച്ച് നടക്കുമ്പോൾ ഷീ ഈസ് ഗെറ്റിംഗ് സം ഡിഫിക്കൽട്ടി ഇൻ ദ ടിപ്പ് ഓഫ് നോസ്, പെയിൻ, ടിംഗ്ലിംഗ്, numbness in the cheek as well as ear lobes, and with the symptoms got aggravated in Munnar. What are the other things we have to keep it in mind? Dermatomyositis will have no relation with the cold or cold wind or something. There is no relation. Reynolds phenomenon in a cold place. Whenever a patient complains of something in a cold, frostbite, then Reynolds phenomenon are the 2 most important thing. Then erythromelalgia, this is another condition where we have to keep it in our mind. Then perineum is another condition we have to keep it in. These are the differential diagnoses we have to think. But this patient is giving a clear-cut history that there is pain, there is ഒരു പെയിൽ ആയിട്ട് വരും. Then അതിന് ശേഷം there is fatigability, there is bluish ഒരു discoloration, and it will disappear over a period of some time. So what our juniors and the PG students did was they collected some ice water and dipped the hand, കൈ അതിനകത്ത് മുക്കി വെച്ച് കഴിഞ്ഞപ്പോഴത്തേക്കും പേഷ്യൻ്റ് കൈ വലിക്കാൻ തുടങ്ങി. കാരണം ഷി എക്സ്പീരിയൻസസ് പെയിൻ, numbness and paresthesia. She took it out. Then there is ആദ്യം പാലറേ ഉണ്ടായിരുന്നുള്ളൂ, പിന്നെ ഒരു മൈൽഡ് സൈനോസിസ് ഇൻ 1 or 2 fingers. ജോയ് സാറേ ഓർക്കണല്ലോ അത്? 1 or 2 fingers. ഇങ്ങനെയുള്ള എല്ലാ അനാശാസ്യ പ്രവർത്തനത്തിനും ജോയ് സാറിന് വളരെ താല്പര്യം, ഇങ്ങനെ എന്തെങ്കിലുമൊക്കെ ചെയ്തുകൊണ്ടിരിക്കണേ. അപ്പോൾ മുക്കി വെച്ചു. അതിനുശേഷം നമുക്കവിടെ വേറെ സൗകര്യം ഇല്ലാത്തതുകൊണ്ട് നമ്മുടെ ഹീറ്ററുണ്ട് തിളപ്പിക്കുന്നത്, ഹീറ്ററിൻ്റെ മുകളിൽ കൈ പിടിച്ച് ഇങ്ങനെ നമ്മൾ നോക്കിച്ച് കഴിഞ്ഞപ്പോഴത്തേക്ക് ഡിസപ്പിയർ. സോ വി made a diagnosis that it may be Reynolds phenomenon. More than that, there is no evidence. Doppler is normal, all pulsations are normal in the upper limb and lower limb also. We thought it is nothing but a vasospastic disorder, Reynolds phenomenon. Then why Reynolds phenomenon? That is another. That is because of scleroderma. Then why scleroderma? That is why never ends. So that why the answer will be the final diagnosis. Okay.
What will be the most probable diagnosis? And we have done the investigation. We have done the ANA, which was positive. ANA profile done showed anti-topoisomerase SCL70 positive. And we have done a skin biopsy which shows extensive fibrosis with infiltrates. And an echo was done which showed moderate pulmonary arterial hypertension.
This is the criteria to make how to make a diagnosis of scleroderma. This is the latest criteria, American Rheumatology Association criteria.
Yes, yeah. This is the ACR EULAR criteria for classification of systemic sclerosis. And the first one is skin thickening of fingers of both hands extending proximal to the MCP joints, which is a sufficient criterion, and the score is 9. And the other criteria are skin thickening of fingers, then there will be fingertip lesions, there will be telangiectasias, abnormal nail fold capillaries, pulmonary artery hypertension or interstitial lung disease, there will be Reynolds phenomenon, and there will be systemic sclerosis related autoantibodies which include anti-centromere antibody, anti-topoisomerase 1 antibody or anti-RNA polymerase 3 antibody. So the
score 9 അതിൽ കൂടുതലോ ആണെങ്കിൽ we can make a diagnosis of scleroderma. നമ്മുടെ പേഷ്യൻറ്റിന് ഫസ്റ്റ് ക്രൈറ്റീരിയ ഇറ്റ് സെൽഫ് ഈസ് സഫിഷ്യൻറ്റ് ടു മേക്ക് എ ഡയഗ്നോസ്. കാരണം അതിൻ്റെ സ്കോർ 9 അതിന് മാത്രമുണ്ട്. പിന്നെ റെയ്നോൾഡ്സ് ഫിനോമിനൻ ഉണ്ട്, അതിന് സ്കോർ എത്രയാണ്? അത് ഞാൻ മറന്നുപോയി. റെയ്നോൾഡ്സ് ഫിനോമിനൻ 3 ഈസ് ദ സ്കോർ. അപ്പോൾ 9 3 12 അത് തന്നെ.
പിന്നെ ടോപ്പ് വോയിസ്
നമുക്ക് 9 തീർക്കണം.
So the final diagnosis was polycythemia rubra vera, and there is Reynolds phenomenon, systemic sclerosis, pulmonary artery hypertension primarily due to underlying connective tissue disease.
So this is our final diagnosis. So if you take the retrospectively, if you analyze the history, the patient first complaint raining seasonലാണ് പേഷ്യൻ്റെ പ്രശ്നങ്ങൾ തുടങ്ങുന്നത്. സ്കൂളിൽ പോകാൻ മടിയാന്ന് പേരൻസ് പറഞ്ഞു. ഒരു ബാക്ക്വേർഡ് ഇൻ ദ സ്കൂളുണ്ട്, അത് പോളിസൈത്തേമിയക്കുള്ളൊരു ഇതാണ്. പിന്നെ പേഷ്യൻറ്റിന് കൈക്ക് വിരലിനെല്ലാം നമ്മനസ് പരസ്തീസിയ വരുന്നു. അത് എക്സേർട്ട് ചെയ്യുമ്പോഴത്തേക്കും അത് കൂടുന്നു, അത് ടൈപ്പ് ചെയ്യുമ്പോൾ കൂടുന്നു. അതിനുശേഷം അത് ട്രമേഴ്സ് വരുന്നു, ഫറ്റീഗബിലിറ്റി കൂടുമ്പോൾ അത് കുറയുന്നു. പിന്നെ സബ്സിക്വൻ്റ് ആയിട്ടുള്ള ഇൻവെസ്റ്റിഗേഷൻസിനകത്ത് പിന്നെ മൂന്നാറിൽ അത് നമ്മൾ റിസർവോയറിൽ സൈഡിൽ ഇറങ്ങി നിന്നിട്ട് കല്ലിൽ തുണി അലക്കിക്കൊണ്ടിരിക്കുന്നു. അത് ഓരോ പ്രാവശ്യം ചെയ്യുമ്പോഴും പേഷ്യൻ്റ് ഇസ് ഗെറ്റിംഗ് ദി പ്രോബ്ലം ബിക്കോസ് മൂന്നാർ ഇറ്റ് ഈസ് വെരി കോൾഡ്. സോ ദി വാട്ടർ ഇൻ മൂന്നാർ ഡാം ഇസ് ഓൾസോ വിൽ ബി വെരി കോൾഡ്. സോ ദാറ്റ് ഈസ് ദ റീസൺ വൈ ഷീ ഗോട്ട് അഗ്രവേഷൻ ഓഫ് ഹെർ സിംറ്റംസ്. പിന്നെ അതിൽ നടക്കുമ്പോൾ പുള്ളിക്കാരത്തെ പറഞ്ഞാണെങ്കിൽ ഞങ്ങൾ മങ്കി ക്യാപ്പും കമ്പിളിയും ഒക്കെ പുതപ്പിച്ച് ഇങ്ങനെ കൊണ്ടുനടക്കണമെന്ന് പറഞ്ഞാൽ കൊണ്ടുനടന്നാൽ പോലും ഷീ ഈസ് ഗെറ്റിംഗ് സിവിയർ പെയിൻ ഇൻ ദി ഇയർ, നോസ് ടിപ്പ് ആൻഡ് അതർ ഏരിയസ്. All these things points to the fact that this is because of some vasospastic, because there is no evidence to prove that there is some obstructive lesion in the blood vessels or arteries. So we came to a conclusion that it is polycythemia with systemic sclerosis, Reynolds phenomenon.
Pulmonary artery hypertension.
It is there association. This association by polycythemia with the Reynolds phenomenon and scleroderma association we searched but we could not find out. This case also we published. The sir? ഇല്ല സാർ, വി ആർ നോട്ട് ട്രൈഡ്. ഡെസ്ഫെറോക്സാമിനും കൊടുത്തില്ല, ഡി പെൻസിലാമിനും കൊടുത്തില്ല. ബോത്ത് ദീസ് ടു തിങ്സ് ആർ കോസ്റ്റ്ലി, നോട്ട് അവൈലബിൾ ഹിയർ. ഇറ്റ് ഈസ് ഓൺലി അവൈലബിൾ ഇൻ അമൃത ഫാർമസി. Some few days she took the patient desferoxamine. അല്ലേ നിങ്ങളില്ല? അപ്പോൾ ഇല്ല സാറ്, ജോയ് സാറ് നമ്മൾ കൊടുത്തായിരുന്നോ ഡെസ്ഫെറോക്സാമിനോ എല്ലാം കൊടുത്തോ നമ്മൾ? ഇല്ലല്ലോ. വി ആർ നോട്ട് ഗിവൺ സാർ, വി ആർ നോട്ട് ഗിവൺ ദാറ്റ് ടാബ്ലറ്റ്സ്. ഡി പെൻസിലാമിനും കൊടുത്തില്ല. നമ്മൾ ഹൈഡ്രോക്സിയൂറിയ മാത്രമേ ടാബ്ലറ്റായിട്ട് കൊടുത്തോളൂ. നമ്മൾ സ്കിൻ ബയോപ്സിയൊക്കെ നമ്മൾ റുട്ടീനായിട്ട് അവർ ചെയ്യുന്നതായിരുന്നു. സ്കിൻ ബയോപ്സിയൊക്കെ ചെയ്തു. പിന്നെ ഉള്ള ഫൈൻഡിങ് നമുക്ക് കണ്ടുപിടിക്കാനുള്ള ഫൈൻഡിങ് വൈ ദർ ഈസ് സ്ക്ലിറോഡെർമ. വാട്ട് ഈസ് ദി ആൻസർ? സോളൈൻ ഡിഫിക്കൽറ്റി അത്രയില്ല, പക്ഷേ ഭയങ്കര ഈ ഗ്യാസ്ട്രൈറ്റിസ് ഉണ്ട്, ഭയങ്കരമായിട്ട് ഒരു ഡിസ്മോർട്ടലിറ്റി ആണെന്ന് വേണമെങ്കിൽ പറയാൻ നോക്കും. നമ്മളതൊന്നും ചെയ്തില്ല സാർ. നമ്മൾ ഇതേവരെ മോർട്ടലിറ്റി സ്റ്റഡി ചെയ്തില്ല. ഇതിൻ്റെ അകത്ത് ചെയ്യാത്ത കാര്യങ്ങൾ ഈസോഫാഗൽ മോർട്ടലിറ്റി സ്റ്റഡി നമ്മൾ ചെയ്തില്ല. പിന്നെ ഗാസ്ട്രോപാരസിസ് ഉണ്ടോ എന്നുള്ള സ്റ്റഡികളൊന്നും നമ്മൾ ചെയ്തില്ല. എല്ലാം ഉണ്ട്. സ്ക്ലിറോഡെർമയിലൊന്നും സംശയമില്ല, ഡ്രൈനോൾസിന് സംശയമില്ല, പോളിസൈത്തേമിക്ക് സംശയമില്ല. ആ അസോസിയേഷൻ വി കുഡ് നോട്ട് ഫൗണ്ട് ഔട്ട് സോ. ആൻഡ് പിന്നെയുള്ള ഒരു കാര്യം, വൈ സ്ക്ലിറോഡെർമ? ഇറ്റ് ഈസ് ഡ്യൂ ടു കൊളാജൻ വാസ്കുലർ ഡിസീസ്. കാരണം ANA is positive 2+. So we can explain everything. So Reynolds phenomenon is a part of scleroderma. Scleroderma is due to collagen vascular disease. ഇത്രയും വരെ നമ്മൾക്ക് പ്രൂവ് ചെയ്യാൻ പറ്റും. ദാറ്റ് ഈസ് വൈ ദ ESR was very high from beginning. എത്രയായിരുന്നു ESR? 2. That is because of polycythemia. Any comments or any further suggestions or alternate diagnosis is most welcome. Regarding the treatment, sir, patient pH is it's a common association. pH is a common association. That is knowing that after reading this only we came to know about these things. അതല്ലാതെ നമ്മൾ പൾമണറി ആർട്ടറി ഹൈപ്പർടെൻഷൻ നോക്കാൻ വേണ്ടി തന്നെ എക്കോക്യൂട്ട് അപ്പോൾ മറ്റേ കുട്ടിയുടെ കയ്യിൽ അതിൻ്റെ ഡീറ്റെയിൽസ് എല്ലാം അങ്ങനെ ഞാൻ പറഞ്ഞത് അതുകൊണ്ട് പിറ്റ്ഫോൾ പറ്റിയത് ആ ഡോപ്ലറും എല്ലാം ഉണ്ടായിരുന്നു ഇതിനകത്ത്. ഡോപ്ലറും എന്തോ ഏതാ വിത്ത് സിവിയർ. അതിന് നമുക്ക് പ്രൂവ് ചെയ്യണം ഹൈപ്പോക്സീമിയ ഉണ്ടെന്ന്. ഹൈപ്പോക്സീമിയ ഇല്ല പേഷ്യൻ്റ്. ഹൈപ്പോക്സിയ ഉണ്ടെങ്കിൽ മാത്രമേ നമുക്ക് ഈ പേഷ്യൻറ്റിനെ സെക്കൻഡറി പോളിസൈത്തീമിയ എന്ന് വിളിക്കാൻ പറ്റൂ. സെക്കൻഡറി പോളിസൈത്തീമിയ ആയിരുന്നെങ്കിൽ സീറം എരിത്രോപോയിറ്റിൻ കൂടിയനെ, JAK2 മ്യൂട്ടേഷൻ വരില്ലായിരുന്നു. മനസ്സിലായി? അപ്പോൾ അങ്ങനെ നമുക്കത് സെക്കൻഡറി അല്ല, പ്രൈമറി ആർട്ടറി ഹൈപ്പർടെൻഷൻ കൊണ്ടല്ല ഈ പ്രശ്നം ഉണ്ടായിരിക്കണമെന്ന് പറയാൻ പറ്റും. We discharge the patient with a calcium channel blocker, amlodipine 5 mg BD. Then we started the patient with sildenafil citrate 50 mg. ആദ്യം ഹാഫ് കൊടുത്തു, പിന്നെ നമ്മളത് 1 ടാബ്ലറ്റ് ആക്കി കൊടുത്തു. പിന്നെ വി ആർ ഗിവൺ സെലാസ്റ്റസോൾ നമ്മൾ കൊടുത്തു. അതിന് റോളുണ്ടോയെന്നൊന്നും ചോദിച്ചേക്കല്ലേ. പിന്നെ പറയുന്നത് ട്രെൻഡാളാണ്, പെൻഡോക്സിഫിലാണ് പിന്നെ ഒരു ഡ്രഗ് പറയുന്നത്. യു ആർ നോട്ട് സ്റ്റാർട്ടഡ് പെൻഡോക്സിഫിൽ, ബട്ട് വിത്ത് ദിസ് മെഡിസിൻ പെൻഡോക്സിഫിൽ നമ്മളെ എന്തെങ്കിലും പ്രശ്നം ഉണ്ടായി കഴിക്കാൻ പറഞ്ഞു. ഇപ്പോഴത്തെ ലേറ്റസ്റ്റ് കാര്യം ജോയ് സാറേ, ലേറ്റസ്റ്റ് എങ്ങനെയുണ്ട്? പേഷ്യൻ്റ് ഈസ് ഡൂയിങ് വെൽ റീസെൻ്റ്ലി. അപ്പോൾ വലിയ കുഴപ്പം കാണും, 3-6-ലായിരിക്കും. ഇപ്പോൾ കാണാൻ വലിയ കുഴപ്പമില്ല. എന്തായാലും പേഷ്യൻ്റ് ഹാസ് ഗോട്ട് എ വെരി ഗുഡ് ഇമ്പ്രൂവ്മെൻറ്റ് വിത്ത് ദിസ്. പിന്നെ ഒരു AC ഇൻഹിബിറ്റർ നമ്മൾ ലൊസാട്ടൻ നമ്മുടെ ആശുപത്രി ഫ്രീലി കിട്ടുന്ന സാധനം, അത് നമ്മൾ 25 mg കൂടെ കഴിക്കാൻ പറഞ്ഞ് ഞങ്ങൾ ലാസ്റ്റ് ഞാൻ കാണുമ്പോൾ വിട്ട്. പിന്നെ എനിക്ക് നോട്ട് ഹൈപ്പർടെൻഷൻ. പക്ഷേ പുതിയ ലിറ്ററേച്ചേഴ്സ് കുറേ പറയുന്നുണ്ട്. ലിറ്ററേച്ചേഴ്സ് സെർച്ച് ചെയ്ത് കഴിഞ്ഞാൽ ഈ AC ആൻജിയോടെൻഷൻ ബ്ലോക്കർ ഡ്രഗ്സ് ഈ ലൊസാട്ടനും അതുപോലെ ടെൽമിസാട്ടനും ഒക്കെ പറയുന്നുണ്ട്. ഏറ്റവും കൂടുതൽ സ്റ്റഡീസ് ഉള്ളത് ലൊസാട്ടനാണ്. ലൊസാട്ടൻ 25 mg കൊടുക്കാമെന്ന് അവർ പറയുന്നുണ്ട്. ഈ പേഷ്യൻ്റ് ഈ ഹൈപ്പോടെൻഷൻ ഉണ്ടെങ്കിലും സ്റ്റാർട്ട് ചെയ്യാമെന്ന സ്പെസിഫിക് ആയിട്ട് പറഞ്ഞു. എന്തോ നിഫിഡിപ്പിനാണ് ഏറ്റവും ഐഡിയൽ ഡ്രഗ് എന്നാണ് പറയുന്നത്. പക്ഷേ അമലോഡിപ്പിൻ ഓൾസോ ഹാസ് ഗോട്ട് ദ സെയിം പ്രോപ്പർട്ടി. സോ വി സ്റ്റാർട്ടഡ് ഓൺ വിത്ത് അമലോഡിപ്പിൻ. പിന്നെ Losartan has got an effect over for preventing the vasospastic episodes on exposure to cold. കുറേ പേപ്പേഴ്സ് ഉണ്ട് അതിൻ്റെ അകത്ത്. ഇവിടെ ഇന്ത്യൻ പേപ്പറും ഉണ്ട് അതിനകത്ത്. ദാറ്റ് ഈസ് വൈ വി സ്റ്റാർട്ടഡ് ദാറ്റ് പേഷ്യൻ. പിന്നെ ഒരു ഡ്രഗ് ഹൈഡ്രലസിൻ. സാറേ പഴയ കാലത്തൊക്കെ എനിക്കൊന്ന് സാറിൻ്റെയൊക്കെ കാലത്ത് ഹൈഡ്രലസിൻ ആയിരിക്കണം അല്ലേ? സാറിൻ്റെയൊക്കെ പീരീഡിൽ ഹൈഡ്രലസിൻ ഉപയോഗിക്കുമായിരുന്നു അല്ലേ? Sir? സെല്ല്. അത് സോ ദിസ് ഈസ് അബൌട്ട് ദ കേസ്.
Very well done. Now we will go for the next session. General body.
I request Dr. Paul Putran sir to present the memento of appreciation to Dr. Jilse sir. I request Dr. Rajiv George sir to present the memento of appreciation to us postgraduate students who present the case, very good case presentations. Dr. Nithya Jose. Dr. Elsu Bejoy. Dr. Faisa.